My name is Sandy Beer, and I am the Chief Operating Officer for the NIHR Exeter Biomedical Research Center. And I want to welcome you to our first inaugural National Institute of Health and Care Research public seminar, where we will be exploring prostate cancer diagnosis and monitoring. The seminar is delivered in partnership with our colleagues from the Exeter NIHR Health Tech Research Center, the Royal Devon University Healthcare NHS Foundation Trust, Exeter Collaboration for Academic Primary Care, APEX, and last but definitely not least, the Torbay Prostate Support Association. I will start by if my slides will go on, just showing you the quick agenda for today. So I'm going to do a quick introduction about the BRC, and then I will hand over to Ian and Mike, and I'll introduce our speakers as we go through the day as well. Just a little housekeeping note is that this event is being recorded, and there will be a question and answer box to pose your questions, and we will save these until the end during the question and answer session. If your question is for a specific person, please indicate that when you ask your question. There is also a chat box available for other issues or questions that you may have with the recording, but please use the chat box, the Q&A for any questions. We'll try to get to as many the questions as possible, but we likely won't be able, hopefully we'll get lots of questions, so we won't be able to get to them all today necessarily. And you're welcome to follow up afterwards if you have a question that we weren't able to answer today during the question and answer session. So what is the NIHR Exeter Biomedical Research Center? Biomedical research centers, which are abbreviated and often referred to as BRCs, are collaborations between world-leading universities, so in our case, the University of Exeter, and NHS organizations that bring together academics and clinicians to translate lab-based scientific breakthroughs into potential new treatments, diagnostics, and medical technologies. So it's really focused on that translate bit of the research. BRC funding supports researchers of the highest caliber to develop innovative translational research ideas that can attract investment from other funders. And another key strand of BRCs is building capacity. So we have studentships, fellowships, and projects that help us to bring forward and increase the capacity for health research within the Southwest Peninsula. So what does that kind of translating scientific discoveries mean? We carry out high quality scientific research into the health areas that are most important to our communities. And this allows us to put people at the center of our work. In order to focus on that, we focus on research, which is a big piece, and I'll talk about our 5 research themes in a couple slides. We also do a lot of training and professional development. And then we have a big team of patient and public involvement experts that also work with our experts within our communities in order to ensure we're meeting the needs of our communities and helps us to focus our research well. And then we work with industry partners that really help us to translate the science further to get it wider than just our local communities or with technologies and push further to market. So we help academics and patient-facing experts like doctors and other healthcare professionals to bring their research to labs and ensure that those scientific discoveries find their way, which we sometimes refer to as translate to the bedside or to a clinic. Here are our partners. So we partner with the Royal Devon University Healthcare Trust here in Exeter, as well as the Devon Partnership Trust, Somerset, both Cornwall NHS trusts, and then St. George's University as well. All of those partnerships are underpinned by a joint research collaboration that has been developed over the last 2 decades with Exeter and helping to facilitate collaborative working for the benefit of people, research, and the healthcare system. I said I'd mention our themes, so I won't spend too much time, but the Exeter BRC has 5 main research themes, and these are genetics and genomics, rehabilitation, clinical mycology, neurodegeneration, and diabetes. We also have 2 shadow themes that will probably come out more in the future. And in the interest of time, I'm not going to go too much detail into those themes, but you can find more information on our website about individual themes, or I'll have the contact information at the end of the time, and you can reach out for more information as well. So as we said, today is our inaugural PPIE seminar series. So I wanted to talk a little bit more about that patient and public involvement and engagement. So patient and public involvement and engagement to us means involving and engaging people with research. It means that people can use their experiences to influence research, supporting its delivery so it is relevant to people's lives, health, and wider communities. Putting people at the center of our research makes it stronger. And we know that listening to the voices of people who live in our communities and who stand to benefit from that research will help us to make treatments, diagnoses, and medical technologies more effective and more useful for the individuals that will be using them and receiving them. Today, as well as hearing about some current research into prostate cancer, you'll hear from some patient groups that support people with prostate cancer and have been invaluable in supporting some of our research and their perspectives and ideas. If you'd be interested in getting involved in research, we'll have more contact information at the end, and we would love to hear from you and help register your interest. So here's that contact slide, but again, I will show this at the end of the presentation. I am now going to stop sharing, and I am going to hand over to Ian Nightingale and Mike Clay from the Torbay Prostate Support Association. So Hat is going to share their slides.
Okay, well, thank you for that introduction. And if we could have the next slide.
And this is Mike, by the way, and I'm Ian.
Ian, I should have introduced Ian. We were formed in 1999, and we recognised that there was a real gap in the market, gap in this area really. Our founder, Peter Hoskin, was a really lovely gentleman who was diagnosed with prostate cancer. There was no support at all in the Torbay area, and so he decided he would form a charity. And during his nearly 20 years of life with prostate cancer, he did enormous work in supporting and raising funds for our charity, and actually was awarded the British Empire Medal and the Queen's Award for voluntary service. I think you probably understand what devastating news prostate cancer can be for not only the man that's suffering it, but from his partner, their friends, the family in general. Fearful thoughts of being alone. And at that time, there was nobody to support that, and hence the Torbay Prostate Support Association was born, in short, the TPSA. The thing that we try and emphasize too is that although it affects the male that has prostate cancer, it also can affect the family generally. And so it's very important that the family tell their children, males, to be aware of prostate cancer in the future for them, and also females, because breast cancer is a very similar cancer, sadly. So we find that our charity brings solace to that person. They know that they're not alone. It improves their mood. And by having this group local support, which is often overlooked, is so important to them for their well-being in general. So we have the next slide, please.
Okay, so you can do the maths that this year is our 25th anniversary year. And what are we all about? Because I think Mike said the value of local support groups. A lot of people look at sort of prostate cancer and they know Prostate Cancer UK, they know prostate cancer research, and they assume that we get some funding from these people and that we're an integral part of that. But you know, we are standalone, and obviously use the resources that come from those organisations. So what are our three main aims? So raising awareness, and we do this by visiting local charitable organisations like the Lions, like the Masons, like the Rotary and the Round Table. We do talks to WIs, we do talks to U3A groups, and only yesterday I had a slot on Riviera FM, a whole hour and a bit, talking totally about prostate cancer and how we can support men, their family and friends in Torbay. It's a little bit of a misnomer. We're called Torbay because that's where we started, but in the whole of Devon, there are only 3 groups. So there's ourselves, there's a group in North Devon, and there's a group in Plymouth. So between us, we have to soak up all of the people that are affected by prostate cancer. So as I said, we provide family, not just to the person suffering with prostate cancer, but also to their families and their friends. And another key thing that we do is we try to raise money for specialist equipment for the hospitals. Only last year did we fund £90,000 worth of a scanner with the urology investigation unit in Paynton. And before that, we a few years ago, we funded something to do with brachytherapy in the Exeter hospital. So an eye to sort of what the hospitals need, but also, you know, the support we can give to the suffering people out there. So next slide, please.
So during the pandemic, we recognized that people weren't able to interact with groups. And so we developed the use of Zoom, something that we had to learn, but that was a great success. And we also, I produce a newsletter now for our group, and that goes out to around 300 people who are our supporters one way or another. We've also realised the importance of this online presence, and we've developed a really good website. We've recently had that completely reconstructed. And on that, we've got our trustee stories of our own experiences of prostate cancer. We try and put information out there for people to look at. And also we've got some links to other websites. And we've been able to reinstate our meetings again following the end of the pandemic. And we realize that face-to-face meetings are so very, very important. We tend to have one meeting per month. One of those meetings will be a medical one, and the next meeting will be really a get-together, an informal talk. And it's then where we realize that the partners, mainly wives of men, ladies, they will get together and speak quite openly about the problems they're experiencing with their menfolk. And one very good example is one of the guys who was on it was a hormone drug to remove testosterone, started to get the same sort of problems that ladies have during the menopause. So I've really got these wonderful, horrible sweats. And the other guy said, well, buy one of these, like a pair of headphones, but it's got 2 fans in it, and that will keep you cool. The next meeting, I've done that. I bought this fan, absolutely fantastic. So we can actually help people as well. And I think that's where we get very strong support group by talking to each other.
Yeah, and I think to sort of say a little bit more on the online presence, I think people assume that the only way of accessing a support group is to go to a meeting, and really that doesn't fit with a lot of people's needs, or if they're working or whatever, it can be quite difficult. So the online presence in our sort of group is also, we've now got a really active Facebook group, and we aim to put on stuff at least 2 or 3 times a week in there. So I think a lot of local groups get disheartened because they send a lot of leaflets out to the hospital and then they don't translate bums on seats. But we realise now that people do interact and need different things from a group rather than purely face to face.
Okay, so can we have the next slide, please?
Yeah, and so I think as Mike was alluding to, we have monthly meetings. So the first one is always a specialist speaker. This year so far, we've had a couple of people, a couple of consultant oncologists to give presentations. We've had somebody from the bowel and bladder organisation. So relevant sort of medical type and support. We've got somebody this month talking about end of life care, and we agonised a little bit about whether we should do that or not. But I think it's something that, you know, we need to talk about. The second month, we'll have a peer-led session. And again, we agonised for a number of years, what should we do this? We thought people just purely wanted medical information, but actually that's probably one of the most successful things that we've done for a long, long time. And we were really surprised at how open people were. And we had, in the first meeting, we had sort of all sorts of stuff. Erectile dysfunction was coming up, and then symptoms mimicking menopausal things, and continence issues. So it was absolutely amazing that people get involved with this. And this last year we've re-energized ourselves with the family and friends group, and we've resisted calling it the partners group or the wives group, because we recognize that relationships are different now than they used to be 25 years ago. So I think the next slide, please.
So, as Ian has mentioned a few of the things, obviously in raising awareness, we are attending different events to try and spread information about prostate cancer and the role of our TPSA and how it can help. We will talk to clubs. We've got something coming up, which is at Torbay Hospital. We're going to run an awareness event actually in the foyer of the hospital, which should be jolly good. TPSA testing, we run events twice a year. We test around about 350 men, and sadly 8% of those get either a red warning letter or an orange warning to just say you may be on that path. All of that, obviously, our awareness leads to donations, and we have somebody that has been in the field of law, so they would be, or that they have in the past and still doing that, offering help with lasting power of attorneys, which can be very expensive, and so we get donations that way around. We're also receiving legacies from people who have died, or family of people who have died. And Ian has mentioned the website. We've also got a donate button on the website, which we hope people will use, and also that they will use the gift aid scheme.
And I think we've recognised any local organisation needs to evolve with technology. So the first event we ran with awareness and testing, we didn't have any card readers or anything, and so the donations were quite small.
Yeah.
Then we had a card reader at the next one. We were so busy with card readers, we now got a second card reader, and so we've evolved and we've moved with the times. And I was out on Saturday with my family. Guy called me up and said, "Oh, I'm chairman of a bowls club. We'd like to consider you for raising money in my chairman's year." So we're really pleased that people will think about us and very, very generously make a donation. So the next slide, please. So I think, as we keep saying, it's our 25th anniversary. So what have we done over those 25 years? So we've raised over £750,000, which we put to raising awareness, that providing the testing events, and supporting equipment for hospitals where we can. It's obviously a voluntary organisation. Nobody's funded. We're all volunteer trustees, and there's 8 of us trying to run the organisation. We've got a supporters list, which I think, Mike, is 200 and something people. Yeah, 296 supporters. We've just been looking at how we tackle the GDPR issues, and so we've got around about 130 where we know a lot of information about them, and the remainder are just emails. And I think sort of we mentioned about the PSA testing. That's one of the main pillars of our organisation. So in the last 2.5 years, we've funded 1,700 PSA tests, and we run those along with an awareness event, because we thought it was wrong just to take blood from people without any knowledge of the support group or what it's all about. We've got another event being run in a few weeks' time, and that'll take us up to well over the 2,000 guys. So that's really it. If anybody's got any questions, then please deal with them at the appropriate time. Yes, we'll deal with them at the end, I believe. Thank you.
All right, thank you so much to Ian and Mike. You're right, we will do questions at the end. So next, I would like to introduce Neil Partridge from the Royal Devon University Healthcare NHS Trust for his section of today's conversation.
Thank you, Sandy. Appreciate that. Now I'm going to try and share my screen here. I've got a brief slide session to show. So just try and do that if I get that running. Okay, so can you see that?
Yes, we can.
You can, and hopefully just the slides and not all my notes. I don't want you to...
Correct.
No, excellent, that's good. Okay, so I'll try and skip through this fairly quickly. I'm conscious of time. So yeah, my name is Neil Partridge. I'm a project manager within our transformation team here at Royal Devon Trust. I'm going to talk very briefly about an ongoing project that we're currently working on, where we've introduced home-based finger prick blood testing into our PSA monitoring program. This project actually started last year, and I joined the project around about April, May time this year, working alongside a colleague who's now left. So I've now picked up the reins and working with a small team of people to move this forward. So brief introduction. So Royal Devon provides acute, secondary and community care across a vast swathe of Devon, actually across the whole of the north and the Exeter and eastern area, eastern part of Devon. And we currently conduct PSA monitoring for patients who've had a prostate cancer diagnosis, and that's pre and post treatment. We're actively monitoring around about 3,000 patients in total. That's 2,000 in the east and 1,000 in the north. Predominantly, those patients have their blood taken in a phlebotomy service, either at one of the Trust's own sites or as a community hub or a local GP. However, we're aware that for some patients, particularly in rural areas, that travel distances, travel time is complicated. It's not always easy for them to be able to attend one of those locations to have a routine test. Prior to my joining, but a number of my colleagues were looking into this around the development of home-based, patient-led finger prick blood collection, which is now possible. The technique has been validated by our Trust's Blood Sciences department, and therefore there was a desire to look at how we could implement this within and make this basically an offer for our patients within our PSA monitoring service. So the Trust decided the best way to do this was to conduct a pilot study, looking at a specific cohort of patients and inviting them to have complete their blood tests at home using these finger prick blood test kits. The aim really was to compare the use of those kits against the traditional phlebotomy service. And in order to enable us to run that project, we sought funding from the SBRI, the Small Business Research Initiative. They held a competition where they were looking for initiatives that were working towards a number of categories, but one of them was around net zero clinical transformation. So we put in a bid for that at the end of last year and were successful in receiving funding, which has enabled us to provide admin and other services that we required in order to get this project off the ground. So most of that took place at the end of last year. What's happened since then? So in the springtime this year, the planning stage took place. We identified a number of key stakeholders within the organisation, so that included laboratory services, urology nurses, sustainability management, finance and digital IT support as well. And a patient advisory group was established. Now that was basically, my understanding was that was established by Hat Porter from the BRC. And I'm pleased to say that some members of that group are on the call today. In fact, Mike, who just spoke a moment ago, is part of our patient advisory group, and they've been a real valuable support to us throughout this project. Then we moved into phase 1. So this was slightly later than planned. We hoped to get this going in around May time, but it started in June, where with a focus on Eastern patients only at this point in order to make the project more manageable. We contacted a small number of patients to establish if they would be interested in taking part. We worked through with those patients to test and refine our process about how we would make this work. Basically, what happens is emails are sent to those patients asking them to confirm their eligibility, and that's looking at a number of questions that they just have to answer, and then assuming that those patients are eligible, they will then be asked to provide consent in order to continue and take part in the pilot. At that stage, a test kit is posted to their home. They will then take the blood sample on or as near to their scheduled test date as possible, and then return the sample back into the lab in a prepaid bag that is supplied to them with the test kit. So we ran through that process with a small number of patients on a couple of occasions, as I say, just to refine the process. And the final part of that was that the samples were then analysed as normal by our blood services department in the lab at RD&E in Exeter, and the results were then updated onto the patient's electronic record. After we'd completed that initial short sample, we then moved into a kind of an expanded stage of the project, so they're into phase 2, and that's where we currently are at the moment. This started in July. So we now have a situation where all of the patients that we wish to invite to the project are contacted automatically by email 28 days in advance of their next scheduled appointment. The patients that complete and return their consent form to us, those are processed on a daily basis now. And at the end of the process, we routinely collect their feedback. As I alluded to, we did have some issues around the digital technology side of things that delayed our start of phase 2. We had hoped to have commenced that in June. However, we are still on target, and that we now have a much more much slicker process that runs so that we're able to, as I say, routinely contact patients without too much manual intervention. Patients are not obliged to consent, I should point that out, and we do have a number of patients that actually, for whatever reason, have not done so. But those that do, they're obviously actively promoted as being part of the pilot study. Just so you've got an idea of what we send to people, this is a sample test kit that we send out. So there are a couple of lancets and cleansing wipes and dressings, as well as obviously the blood collection tube. And the instructions. This is sample instructions. These aren't exactly the same ones that we are now sending to patients. But all of this was prepared with consultation with members of our patient advisory group, and we refined the content based on their feedback. So that just gives you a brief example of what we send out to people. The Trust have identified sort of 3 main core areas where benefits may be delivered. And we're looking at a range of issues here. So the first one is the clinical impact. Improvements really in the regularity of PSA testing for some patients. As I mentioned at the beginning, it is tricky for certain patients to be able to routinely attend phlebotomy tests by having to travel. So what we're looking at there is whether or not this allows those patients to have an improvement in terms of the regularity of their tests. We're also looking at the environmental impact, and this is obviously a big point in terms of the grant that we got at the beginning. So here we are monitoring the distance that people travel from their home to their normal place where they would have their blood test taken, their modes of transport, and we're looking at the number of people that would use community hubs versus GP surgeries. So the overall intention here is to reduce the care miles, as I've put it there on the screen. And then obviously, as always, there's a financial impact. So we're looking at the cost benefits of delivering more capacity within the phlebotomy service. And we're looking at a range of issues here around the costs of the GP service, the standard costs of our own phlebotomy services at those community hubs, the costs of the test kits and how much it costs for the lab to analyse them, and also the administrative burden for the existing service and for this new intervention. Obviously, there are people behind the scenes who are doing an awful lot of admin work to keep all of these things joined up. So we're looking at all of those issues, but those are under those 3 sort of core headings. So our story so far, now, as I mentioned, we had a bit of a slow start. From the very small sample that we began with, our first patient consent was received on the 5th of June this year. However, as I mentioned, patients are now automatically being invited to participate 28 days before their next test is due. As of yesterday, I ran a report which showed we've had 176 patients who have consented to the pilot. And of those, we've had 39 that have now completed feedback surveys. So those are people at the end of the process. So whether they've been successful, provided us with the sample that has been analysed and they've had their test result, or for those patients that have received a test kit, have either decided not to go ahead or struggled to go ahead for whatever the reason may be. Excuse me. Now, patient satisfaction and feedback is vitally important in this. So every patient who has consented are subsequently sent a survey at the end of the process, and that's how we're generating these results. I would say that with those 39 feedback surveys completed at the moment, there are an awful lot of surveys that have been sent in the past couple of weeks. That's down to me. I've had a holiday. As I've been catching up, I've been making sure that those surveys have gone out. So we should, if we review this in a couple of weeks, I would expect that number to be considerably higher. Some common themes that we've had responded. Some people have queried the efficacy of the test. They want to compare the finger prick test to a blood test, to a routine blood test. So we've had to reassure them that that has already been established and that the finger prick testing result is absolutely fine. It's, you know, there's going to be no, this isn't a test to prove whether or not the test works. We've understood that. This is just to see whether this is a viable offer for patients to collect their blood sample in their own home. Some patients have struggled to provide enough blood, and that's been a common theme. So we're aware this isn't going to work for everyone. On the plus side, the majority of people found that the test was quick, easy, and was not painful. And the majority of people would prefer to have a finger prick test in the future as it's more convenient. We've also captured the fact that at the moment, 70% of patients travel to their routine appointments by car, which isn't a great surprise, really. But that's, you know, that's a useful figure for us to capture. Their average travel time is around about 11 minutes. So all of that information is being captured, and we are going to record the impact, the carbon impact of that at the end of the survey. And just a couple of quick charts just to put that in a graphical format for you. So a couple of the questions that we ask people at the end are around the convenience and whether they would prefer the test. At the moment, we're looking at around about a 70% positive response to all questions, and that's borne out by the graphs on the screen there. The majority of people agree or strongly agree with both of those that I've put up as a sample on the screen. So just to round up, what happens next? So we're going to continue with the current process until late October, early November. The target for us is to hit 500 patients by the end of that point. Internally, we're making sure that our processes are working correctly around our nursing and our admin functions to make sure we've got support to process those daily consents, update the results, and collect the feedback. As I mentioned, the feedback is really, really important. I'm going to make sure that we respond to patient feedback, as well as completing the survey. A number of patients have contacted me directly with queries, so it's making sure we answer their questions, provide some reassurance, or if needs be, actually feed that back into the clinical teams. Also going to reach out to patients who haven't consented just to try and understand why that may be. We're aware that a number of people don't necessarily engage with email as a means of communication. So we're going to look out and look at how we might be able to reach those patients. And at the end of the project, we'll be developing reports on the environmental and the financial impact, linking back to those three core elements that I mentioned earlier. Obviously, as well as this being viable for patients, we need to know that it's financially viable and that it's had a positive impact on the environment as well in terms of the NHS greener agenda. And as I mentioned there, we're working towards a target of 500 patients being consented by the end of the pilot in November. Okay, So that's all I was going to say. I appreciate that was a bit of a rush through there. I am conscious of time, and I'm aware that we'll be taking questions at the end. So hopefully that's okay for the time being. And if anyone's got any questions, I'll gladly try and answer them at the end of the session. Thanks very much.
Thank you, Neil, for that presentation. I am going to hand over to Dr. Green, who is a lecturer in health data science at the University of Exeter.
Thank you, Sandy. I'll just share my screen. Can everyone see this okay?
Yes, we can.
Okay, thank you. So I'm going to be talking about some recent and ongoing work at the University of Exeter on using genetics to help triage people who are presented to their GP with symptoms of prostate cancer. Like Sandy said, I'm Dr. Harry Green. I'm a lecturer in health data science at the University of Exeter. So a little bit of background to prostate cancer. The statistic at the top is from Cancer Research UK, that report prostate cancer is the second most common cause of cancer death in UK men. And the NHS guidelines for diagnosing prostate cancer is to offer a PSA test in people who present with symptoms of prostate cancer. These symptoms are typically erectile dysfunction, difficulty with urine control, that sort of thing. And to consider a referral on a 2-week wait pathway if PSA levels are above a specified threshold based on the patient's age. The threshold is higher for older patients because PSA naturally rises throughout life. And 82% of our prostate cancer cases in the UK are diagnosed following a primary care presentation. So this is a huge area where if we can make even small improvements on how we diagnose these 82% of our cases, we could have a massive improvement in patient benefit. As I mentioned, the current diagnosis pathway is a person with symptoms attend their GP clinic. The GP will assess patient factors and symptoms and then decide to offer a PSA or not. If a PSA result is positive, they could possibly be referred for procedures such as a prostate biopsy, which a lot of people don't want, whether that's because of fear of infection or fear of the pain and recovery period afterwards. It's not a condition that people are happy to sign up for. And the symptoms that we're looking at include frequent urination, hesitancy, urgency or retention of urine, blood in urine, or erectile dysfunction. The problem is that the predictive power of the PSA test is quite modest. These statistics vary a lot depending on what sources you read and can depend quite a lot on what demographics you're testing it in. But about 70 to 80% of men with an elevated PSA who have a prostate biopsy do not have cancer. So these are people who are undergoing a prostate biopsy that never needed it because they didn't have cancer. So what I wanted to look at was whether there's a role for using genetic predictors during this primary care triage process. So when I'm talking about genetic predictors, I'm talking about something called a genetic risk score. There are 250 common genes that affect our risk of prostate cancer by a small amount. Genetic risk score, or GRS, combines all of these into one predictive score that can give you your personal genetic risk of cancer. So everybody has a GRS for prostate cancer, but a low GRS will mean your risk is lower than the background population, and a high GRS means you're at a higher risk than the background population. And this isn't something that's specific to prostate cancer. We can calculate a GRS for any human trait, including other cancers, other diseases like diabetes, and even how tall we are. But in relationship to cancer, my slides aren't moving properly. So this graph has a lot of information on it. Along the x-axis are different cancer sites, and this shows how good our genetic risk scores are at predicting cancer. On the y-axis is predictive accuracy, where 0.5 is essentially random chance, like flipping a coin, and 1 would be a perfect predictor. The green box refers to all available risk factors that are not genetic, and the blue box is what happens when we add genetics to that. So I'm going to talk you through lung cancer at first, because it's quite easy to explain. The non-genetic risk factors give you a score of 0.84. So it's lung cancer, so smoking, And adding our genetic risk score on top of that gets you to 0.85. So it doesn't provide a lot of improvement because most of the information is given by whether you smoke or not. But over here in prostate cancer, the non-genetic risk factors all combined, so these are mostly age, have a combined score of 0.71, and adding genetics on top of that gets you to 0.78. So here there's a big increase in the predictive power you get when you use genetics. But does any of this matter if someone is in their GP clinic with symptoms? It's possible once you have symptoms of prostate cancer, your genetics aren't relevant anymore. And there were two experts in Exeter that both had differing views on this. And one of these experts had funding to do a study on it. So that's where I come into this. So I turned to the UK Biobank resource, which some of you may have heard of. It's a big data resource, it's quite often in the news, which has GP notes, cancer registry data, and genetics data on 500,000 people in the UK. These people were recruited age 40 to 70 in year 2006 to 2010. So we looked at people with symptoms of cancer in the linked GP notes, used the genetics data to calculate their genetic risk score, and then we used the cancer registry data to find out if they got cancer shortly after their symptomatic presentation to their GP. So I've summarized this in a study timeline. So we found 7,000 people with a record of prostate cancer symptoms in their GP notes. And this middle box here shows a timeline of people's progression through the study. So 153 people had a record of cancer prior to their first symptom records. We excluded those from the study because they would go down a different pathway if they presented to their GP. So of the remaining 2,700-ish people, about 250 had cancer within 2 years of their symptomatic presentation, and about 6,500 people were cancer-free after 2 years following symptoms. So our study question is to see if genetics can help us tell apart the 247 from the 2,468. We found that the genetic risk score has fairly good risk stratification power to predict 2-year risk. What I've done here is group people into quintiles. So the red graph here, red line here, are people in the top 20% of genetic risk, and people in the purple line have the lowest 20% of genetic risk. So each line refers to 20% of the population ordered by their genetic risk score. And we can see here those in the highest 20% of genetic risk had a prostate cancer risk of about 8% within the 2 years following their symptomatic presentation. And people in the lowest risk groups down in the purple and blue line had a risk of about 0.5 to 1%, which is quite similar to the baseline risk without symptoms. And we don't just have genetic risk scores here, we also have age. So we can combine age with the genetic risk score to give a better prediction of a patient's likelihood of having prostate cancer. So if we look at the under 50s first, prostate cancer is very rare in the under 50s. So even in the bottom, even in the 0 to 80% risk category, we don't find anybody with prostate cancer in the first, second, third, or fourth GRS groups. It's only in the top 20% of genetic risk we find anyone who had cancer within 2 years of symptoms. It's in this 50 to 60 group and the 60 to 70 group where the genetic risk score could be really useful for risk stratification. We find that in the bottom 40% of genetic risk, people had about 1% risk of cancer. But in the top 20% of genetic risk, people had about 5% risk. So depending on your genetics in this age group, your likelihood of cancer could change from below 1% to above 5%. Similarly, in the 60s to 70s, people in the really low genetic risk group had about a 1.2% risk of cancer, and people in the top genetic risk group had about a 14% risk of cancer. Whereas in the over 70s, the risk even in the lowest genetic group was about 2.3% of people with symptoms. So where we've got the most power to risk stratify using genetics is in the 50 to 60 and a 60 to 70. Most PPIE groups have reported that patients would prefer to be further investigated if they have a risk of 2% or higher. So in the over 70s, everyone would be wanting to be referred, but it's in that 50 to 60 and 60 to 70 group where we can really tell apart genetic risk. So we've heard a lot about the PSA test, and that's the currently used test to predict prostate cancer. And the statistics we get from our model in its power to predict prostate cancer is quite similar to the currently used PSA test. But we think that the future of predictive medicine shouldn't be focused on the best test, but on combining all of the information available to us. And what we really wanted to do was combine the PSA test with the genetic risk score to build an even better model. But unfortunately, using the data that I have, the UK Biobank, the PSA test was quite badly recorded. It doesn't appear in GP notes where we know it should be there. So we haven't been able to do that yet. But we are working towards that with funding from the BRC to build a predictive model that could combine PSA with genetic risk score. And this could help in two ways. People with a low genetic risk score could help avoid unnecessary prostate biopsies, which could help reduce an overloaded NHS waiting list and allow better optimization of resources. Whereas people that have a high genetic risk score that have a sub-PSA threshold currently might still be not being referred for prostate cancer when they actually need it. And we have about 23,000 from the BRC to build such a model using a data set in Bristol. So in this data set, everybody had PSA recorded and they also have genetics on the cohort. So we're aiming to use this data to help build a combined risk model where we can combine GRS with PSA to evaluate whether this would have an improvement that has clinical benefit. And also compared to the UK Biobank, the data in Bristol has more information on stage and grade of cancer. So we can ensure that the people being referred through our model would have clinically significant cancer. Work on this is still ongoing. So thanks everyone for listening. I'd like to acknowledge people that have helped throughout this study. Sarah Bailey is an Associate Professor of Primary Care Diagnostics and was a study lead on the UK Biobank work. Bethan Malabar-Rimmer, who I think is on the call, did a MSc project with me last year, doing a similar study in colorectal cancer. Wawa Chen and Jingjian Liu continuing this work on the Bristol data set and doing further work on combining PSA tests with genetic risk score. So thank you everyone for listening. I see a lot of things in the chat come up through the talk, and there'll be time for questions at the end. Thanks everyone.
Thank you, Harry. I am going to now hand over to Dr. Martins, who is a Senior Research Fellow and Lecturer at the University of Exeter, for his portion of today's conversation. We cannot hear you.
Yes, I just
Perfect.
realized that I was on mute. Can you see my screen now?
Yes.
Thank you. Thank you very much for the introduction. My name is Tanimola Martins, and I'm a researcher at the University of Exeter. What I would like to share with you today is some of our findings from looking at PSA, that's prostate-specific antigen test values across ethnic groups. This is essentially a teamwork. My colleague Elizabeth Down might be on the call, did most of the hard work, but I've included my email address here just in case you have any questions that we're unable to cover during this call. We all know how important prostate cancer is, and this is why we're all here. You would have seen some of these figures at the bus shelter or somewhere in the city saying 1 in 5, 1 in whatever numbers, we know this. What I would like to share here is the fact that for some men, the risk is doubly high. And this is the case for Black men, who are not only more likely to be diagnosed with prostate cancer, but also more likely to die from it. I want to point out the fact that these figures are often generated from a man's lifetime risk, which can be a blunt tool for assessing somebody's risk of dying from a disease, because it doesn't take into consideration what we call competing risk of death. Men who have a heart failure or something before their prostate cancer diagnosis may die earlier, and we might think this is due to prostate cancer. Perhaps we need more better means of measuring somebody's risk, because as Harry alluded to, that not all men will have a clinically important prostate cancer. Some will have slow-growing prostate cancer that will never bother them in their lifetime. So that's why I want to point out there that the actual risk might be slightly smaller than these figures are showing. And as a Black man who is approaching that golden age, with many friends who would like to be told they look 25 even though they are 55, you will have this concern somehow, as you're approaching this age, that this could be me in a few years' time. If Black men are more likely to die from this disease, then we should think of what we could do to change this. If not for us, for people coming behind. And we all know that advanced stage makes a lot of difference. A man who has early stage prostate cancer will live more than 10 years in many cases than when a man is diagnosed with very late stage prostate cancer. And so we know that the biology of the disease matters. A man who develops the aggressive type, that fast-growing prostate cancer, is likely to be diagnosed with a late-stage disease compared with a man with slow-growing one. So that we know that, and we know that some Black men tend to develop the aggressive prostate cancer. If a man is aware of symptoms and they present early to their doctors, their chances of being picked up with an early-stage disease is also high, But there could be other problems. There could be delay within primary care after a man presented their GP. There could also be delay in secondary care. Now, we've been doing some work, and some of these have been published anyway, that suggests that Black men are not less aware of their risk of prostate cancer. And they are not more likely to delay presenting to their GP. As a matter of fact, men simply delay. Whether white or Black, men just delay going to their doctors anyway until something serious starts to happen. What we've also seen is that there are no differences in the time spent once a man is within primary care across ethnic groups. Black men are not more likely to be to experience delay in primary care. However, our recent work, which we've sent for publication, seems to show that there are differences in time spent in secondary care, such that it takes roughly about a month, actually 40 days longer, to diagnose prostate cancer in Asian men compared to white men. Yeah, look out for that study. Will be published hopefully soon. So that's what we know, that the things that we think might be contributing to the advanced stage or differences in mortality we are seeing across ethnic groups might be solely around the disease biology. But patient experience also matters. So delay in secondary care would not be very welcome by many patients. So Harry is, shown us this diagnostic pathway, which I'm not going to go over again, that the patient may present symptoms, and some men, if they are over the age of 50 and they are concerned about prostate cancer, they can ask their GP for a PSA test. But the PSA is usually the starting point. I've seen in the chat there people saying that their friends or network wouldn't like to go for biopsy, etc. And we have MRI now that precede the biopsy. In reality, some of the men we are chatting to seems a little bit concerned about the tendency to feel claustrophobic in the MRI scan itself, and the biopsy needle is not particularly small. If you get what I mean there, and so that can actually scare a lot of men and we need to continue to improve some of these diagnostic procedures in order to encourage men to come forward and their disease found early. So that's what I want to say about the diagnostic pathway, since Ari's explained that bit anyway. But going back to our subject of interest, the PSA, Ari again said how unreliable the test could be. But as far as we are concerned, it is the very first step. It is readily available for many, many countries around the world where MRI can be afforded. PSA will continue to be an important test kit for identifying prostate cancer. So it's an incredibly important test, but we have to use it correctly. In the UK, if you have symptoms or you are concerned, your GP can offer this test. There are fixed thresholds. If a man has, this blood test, if a man has a value that is higher than 3 nanogram for the milliliters of blood, GP may choose to refer them based on several other factors. But there is a consideration that as we age, PSA levels tend to rise. And for that reason, clinical guidance suggests or recommend the age-specific threshold, which is shown there on your screen. However, we know that PSA values also vary by ethnicity, and we know this once we conducted this systematic review a couple of years back. And what we found from that review is that among men who haven't actually developed prostate cancer, when you look at their baseline PSA, the ones among Black men is far, far higher compared to men of other ethnic groups. I must say that most of these studies were conducted in the US and none was conducted in the UK. And so this would be reflecting what is happening to African Americans rather than all Black men around the world. So what we wanted to find out is, how is this test performing among men in the UK? And could there be an explanation for differences in prostate cancer incidence, or the number of people, Black men diagnosed with prostate cancer or dying from it in the UK? This is what we wanted to find out from this study. And basically what we did is to look at patient record. Over 750,000 men who have had a PSA test done, and they have their record within the GP record system in the UK, which we could access from a database called the Clinical Practice Data Link, CPRD for short. So we identify all of these men, and we follow them up for years, at least 1 year, to see who eventually was diagnosed with prostate cancer. I must say that we limited this to men over the age of 40, or at least 40, which I think we might, want to look at younger men in the future. But that's the limitation of this database, data set rather. So just quickly to tell you about the men in that study, the vast majority were white, but we have sufficient numbers of Black and Asian men in that study. Mixed and other ethnic groups were far, far fewer. So around 37,000 Asian and about 31,000 Black men were in that study, compared to over 649 white men. But that is not a problem for this study. I must say that the vast majority of Black men at the time of study were much younger, about 10 years younger compared to white men, about 54 compared to 64 there. And the majority of the Black men lived in area with significant deprivation. Interestingly, far fewer of the Black men had existing condition, any comorbidities at the time of testing, compared with white and Asian men. And looking at the results of the PSA testing they've had at their GP, we found, consistent with report from the systematic review reflecting what's happening in America, average PSA value in a Black man is 1.63 compared with 1.39 and 1.39 in the white group and 1.02 in the Asian group. When you look at those with raised PSA, either using the fixed reference or using the age-specific reference, the proportion among Black with raised PSA was far, far higher compared with white or Asian men. Asian men tends to have lowest PSA value and the lowest proportion with raised PSA values. And then we were interested to see who among these men were eventually diagnosed with prostate cancer. And this graph is just showing the odd ratio. I just say the likelihood of having prostate cancer once you have a raised PSA. The yellow line represents the Black group, the blue represent the white group, the green here represent the Asian group. As you can see, the proportion or the odds of having prostate cancer is far lower, is lowest in the Asian group and highest in the Black group, which is consistent with what we know that Black men are more likely to have prostate cancer. And when you look at the distribution across different age groups, you can clearly see there right from the age of 40 up until the age of 70, so the blue line here represents the Black group, the orange line represents the white group, the green, the Asian group. So what we can see here is right up to the age of 70, Black men continue to have a higher incidence. So more Black men being diagnosed with prostate cancer once they have raised PSA. Suddenly, for some reason, beyond the age of 70, that number starts to fall sharply with other groups. You can see there's a falling, the trend seems to be falling for all of the men at that age group, maybe because during that age group, what you benefit from treatment starts to be lower. And so, but we can unpick that later on. It's the trend. Now, this is the important bit. Once a man have high PSA value, what is their risk of having an advanced stage prostate cancer? Because this is the one that tells you how the PSA test is really, really performing. And what we found was that there was no difference between Black and white men in the likelihood of having advanced stage prostate cancer once a man has raised PSA. The Asian men continue to have the lowest proportion with prostate cancer and the lowest proportion with advanced stage prostate cancer. So this is suggesting that, well, maybe the extra or the fact that Black men have higher baseline PSA may be contributing to the incidence and actually not leading to any clinically or extra clinically important disease in Black men compared with white men. And when you look at it across the age, again, the blue line represents the white group, the orange, the blue line represents the Black group, orange represents the white group, and the green, the Asian group. What we can see is right from the age of 40 up until the age of, say, 59, of 50, there seems to be a higher incidence of advanced stage prostate cancer in Black men. Of course, the confidence interval seems to be crossing over each other. And so we cannot confidently say that the risk of advanced stage is high in Black men, but it may be higher. We need to look closer to this data, particularly younger Black men, younger than 40 as well. But beyond that age, it is neck and neck with the white group. And for some reason, beyond the age of 60, and 69, the incidence of advanced stage disease start to fall in Black men, whereas in the white men, it continued to rise at that stage. Overall, what we're seeing there is that Black men may have higher incidence, which may be due to the biology, and we may be finding more prostate cancer in these men because they have higher baseline PSA. Maybe many of these prostate cancer are slow growing anyway, which we shouldn't have been, which may not bother these men in their lifetime. So we need to rethink how we use PSA. A recent analysis that we've done to look at what then happens to these men who have been diagnosed with prostate cancer. And this is looking at net survival across ethnic groups. So the green, light green here represent the white, and the darker green represent the black group. If we focus on those two bars for the moment, you can see that the 1 year net survival seems to be similar between white and black group. And when you get to 3 years and up to 10 years, it looks as though black men are surviving prostate cancer much longer than white men. Now, these are preliminary analysis which we are about concluding and sending for publication soon. So some of these figures may change slightly, but what we are seeing from the data is there is no real evidence that black men are surviving prostate cancer as white men. The survival seems to be similar or even better in black men, even when you look across different stage of diagnosis. All this is suggesting is that perhaps PSA is adding to the number of black men that we're picking or we're finding to have prostate cancer, and that is not necessarily leading to clinically important prostate cancer diagnosis. Obviously, we haven't done richer analysis to look at how this PSA is impacting on investigation done, biopsy, etc., and look closer into who is dying from the disease. So future work, which we are planning, will really look deeper into possible harm due to prostate cancer in black men. I hope I have not taken too much of a time. Like I said, it's a teamwork, and I would like to take questions afterwards. Thank you so much for your time, for listening.
Thank you so much, Dr. Martins. I am going to hand over to Graham, who has experience of prostate cancer and is a member of the advisory group for the PSA home testing project next.
Good afternoon, everyone. This is a quick anecdote about my experiences, because I know we're already overrunning, aren't we? 2019.
Take your time, because we want to hear. Take your time, because we want to hear from you. We'll prioritize you over questions, please. Thank you.
2019 is when I first went to the doctor because of a groin. I thought a groin strain, but she then did a digital examination for me, found that my prostate was enlarged, which is quite common at my age, but smooth, which can be an indicator that if there is anything wrong, it's still inside the prostate. However, she then referred me for a PSA test, and the reading came back at 4.92, which she said should be less than 4 for my age, and referred me to the specialist. We didn't expect it to actually pass to the specialist, because anything under 5, apparently they tended to just pass by and say, we'll look at it again later. But maybe because it was COVID, they agreed to review me again 6 months later and have another PSA test, which resulted in a 5.2. I presume, and I never got a chance to talk to the specialist about it, that the reason that they then took a next step, which was a scan, was because of the differences over the 6 months. The scan showed up something that shouldn't have been there. And as a result, I then went for a biopsy. This showed that I did have cancer, that it was, in theory, because nobody can be 100% certain, still encapsulated within the prostate. But it was close to the left side of the nerves, and they would, if I had the prostate taken out, they would have to be removed. The PSA was the baseline to get me to that point, and I think it's an excellent test. I know there's always criticisms over accuracy and how it works, and how it can possibly make you have tests that you don't need. But at the end, someone has to start with a base and work from there. We, as a family, decided that I would have my prostate removed. This was the best route for us, I think, mentally, and because we were not capable of accepting cancer within my body staying there. This was a major change of life for all of us, emotionally and physically. The operation actually was the easiest part in February 21. Walking into the hospital on your own and walking out because it was COVID, it was quite an experience. But the significance of all the changes to me didn't really hit home until after. The fact that you had a catheter to start with, which was an unusual experience, mind you, it was the first time I'd managed to have a good night's sleep because I didn't need to get up to the toilet for quite a long time. No erections, loss of sexual urge, loss of length of the penis due to the section of the urethra being cut out, incontinence, and mental health issues, which ended up being the biggest problem for myself. All of these issues were experienced in one degree or another. And then following that, the physical rehab starts, which you don't realize how intense it will be. For the first 8 weeks, obviously, you have to allow your body to heal. But then after that, because of having the prostate out and the nerves being asleep, because I only had one set of nerves left, there was no capability of erections. And we had to start using the pump. And the pump is for two reasons. It's for the physiotherapy on your prostate, on your penis, to fill it with blood, which is what naturally happens to men during the night, to make it work and keep itself alive, and also to try to re-lengthen the penis, which you've lost a certain amount of, and it can vary according to how much of the urethra is cut out. I'm 3.5 years on and still they're asleep, so I'm still using the pump. But with that, every day we have to do Kegel exercises. When the prostate is out, part of your bladder control is the prostate, and therefore you need to strengthen all the muscles on the base of your groin, similarly to a lady does after quite often after having given birth to children. I have one set of nerves, as I said, and we've tried with Viagra to see if it still will work, because Viagra will only work if you have some nerves. For many it does, but however, it was only possible if the nerves are spare, and in my case, they're still asleep, even though they are spare. Consequently, I'm actually on injections to give me erections. They work, but as I said, it is life-changing because it's not spontaneous. It's not something most men want to do, but it certainly works and gives you peace of mind in that area of your life. The PSA test resumed after 3 months after the operation, and my PSA was undetectable because they did believe that everything had been removed. The same applied for 12 months, when I went to 6-monthly testing, and then it rose, and they brought testing back to 3 months to give me more active monitoring. Again, it has been stable since then. The PSA test to me is the most important starting point for all of the activity to do with prostate cancer. It's a very simple to have. It gives a clear baseline for us and for the doctors to decide what action could possibly be taken. There are many developments, as we just heard, to look into new ways to check for the prostate cancer. And in the meantime, I believe the PSA is very effective. Anyone who wants reassurance should have a test. It's not only the older who get this problem. As the youngest person I know is 44. It is called the silent killer. A simple PA test may just stop that happening to all of you, but men are extremely difficult. They do not like talking about personal issues. And I think we have to develop more awareness and more openness, which I think the ladies help within the partnerships, or the other partner helps, to ensure that less people die from this disease. Thank you very much.
Thank you, Graham, for sharing your experience. We really appreciate you being here with us today. So I appreciate everyone being here with us today and sharing your experiences and your expertise in this area. And this was our first one, so we look forward to hearing any feedback from you as well. And we will plan to do more of these types of events in the future. So thank you, everyone, for participating today. We're really appreciative that you joined us.